Hello, my name is Fergus Jepson. I'm one of the Year 3 medical students, and I've come to do an examination today. I hope you're expecting that. Um, may I just check your name and date of birth, please? Great, and marvelous. And how would you like me to refer to you, sir? Excellent. Well, Dave, I want to just tell you a little bit about the examination today. Firstly, it's in front of the examiner, and so they're going to act as our chaperone, if that's okay. And then I'm going to tell you a little bit about the examination. It's going to be a rectal examination, so that will involve me essentially having a look at the skin around your anus, having a look at the between obviously parting the buttocks, looking the skin around the anus, and then digitally putting a finger up your back passage to then feel the tone of the muscle in the anus itself, and then to have a feel of the tissue which comprises of the rectum, and then anteriorly, then I'll be also palpating your prostate as well. This shouldn't be painful, but it is uncomfortable. And you just need to try and relax as much as possible. And it helps if you can lie on your left side and bring your knees up as high as possible and just try and relax as much as you can. Do you have any questions about the procedure at all? We can certainly talk about any results of what we find afterwards, if that's okay. Great. Right. Well, without further ado, in that case, I just mentioned I am going to be speaking to the examiner whilst we talk, if that's okay, whilst I carry out the procedure. Marvellous. Looking at the bedside, there is no sign of any drips. The patient does not look unwell, normal body habitus, no sign of any infections such as it requires antibiotics or anything like that on the bedside. Looking at the patient, like I say, looks well. Are you in any pain at all, sir? No, great, marvelous. And there's no chart to suggest there's a fever at all. Moving on to examining the patient, I shall don some gloves to perform the examination, of course. And I would want some of appropriate jelly, some lubrication, and also some paper to do the wiping up with. So first off, prepare by having the lubrication ready to apply, and then on inspection, would look at the buttocks themselves. To assess the skin, and then part the buttocks, and of course the model's already parted. And then I'll be looking for any sign of fissures, fistula, excoriation, hemorrhoids, any masses. Also, of course, any bleeding, any erythema, which might suggest something like a pilonidal sinus or any kind of infection, really, or any masses, of course. So once I've completed the inspection, I can see nothing abnormal there. I will then just tell the patient. So what part of this examination, sir, is I just need to test the sensation of your skin. So first off, I'm just going to touch the skin around the bottom and then the anus, and tell me whether or not you can feel me touching you at all. So could you feel me touching you there and there? Great. Right, I'm going to proceed with the examination now. So I'm going to apply some gel, quite a reasonable amount of gel. And then what I'm going to proceed to do is to just part the buttocks and then just swipe upwards and place my finger inside the rectum. Right, that's okay. Now, so could you just squeeze my finger? That's like bearing down. Marvelous, that's great. Okay, just try and relax as much as you can, sir. And I'm just going to now just have a gentle feel of what's going on, and feeling the rectum, the posterior wall of the rectum. There's no masses and there's no irregularity. There's no nodules at all. And then feeling around the top, the right side, I can feel nothing abnormal. And then down the left side, again, I can feel nothing abnormal at all. no abnormal tissue at all. And then going around the front to where the prostate is, I can feel the sulcus of the prostate, which feels normal. I can feel the left lobe where there's no abnormalities. It's smooth, it's a rubbery firm, and the sulcus feels normal, like I said. And then over to the left side, which again feels absolutely normal, and it's obviously non-tender as well. Right, I'm going to withdraw the finger, sir, so it's just a little bit uncomfortable. Okay, right, and so marvelous. Have a look at the fecal smear as well to see what's on. What sort of is there any blood? What is the consistency of the fecal matter? And if there's any significant amount of mucus, which there isn't, then I would attempt to clean the patient and give the patient something also to clean themselves with and cover the patient up. So I would then take a full history, carry out a full examination, and also examine the inguinal lymph nodes and the external genitalia. If there was any suspicion that there was anything untoward, which is suspicious of prostatic carcinoma, then I'd carry a full systemic examination out just to assess for metastases. If there wasn't also any concern, I would arrange an ultrasound scan, a biopsy, and do some blood tests. Look for HCG, PSA, and an FP. I would do the PSA after carrying out before carrying out the PR examination, because doing it can increase the PSA level in of its own self. Any questions, sir? Thank you. Thanks very much, sir.
So with the models that you'll find in the clinical skills labs, there will be 5 different types of prosthetic insert. These prostates really are a normal one, 2 which are benign prostatic hypertrophy, and then 2 which are prostatic carcinoma. If you look at the profiles here, you can clearly see the normal is flat and with a fairly shallow sulcus. Then the unilateral benign prostatic hypertrophy has got one raised lobe, one large lobe, and then the bilateral has 2, and the unilateral cancer has irregularity of one lobe, and then the bilateral has irregularity of both lobes. So again, just a little close up on the normal prostate. You can see it's a shallow sulcus, symmetrical and smooth lateral lobes. The unilateral BPH, you can see, still has a relatively shallow sulcus on one side, and it's raised quite high on the other side. And you can see that there's a significant smooth projection of one of the lobes of the prostate. The firmness of it will still be quite similar to the rest of the prostate. The bilateral benign prostatic hypertrophy will have quite a deep sulcus, very deep really, and symmetrical enlargement. Well, not necessarily symmetrical enlargement, but on the model it will be. But in reality, it won't necessarily be symmetrical enlargement, but it'll be enlargement, and it'll be that sort of rubbery consistency, again, a little bit like a boiled egg, rather than something which is very hard and irregular. Unilateral carcinoma of the prostate will show irregularity on one side, and will quite likely, but not necessarily, but will in the model have a normal shallow sulcus. A bilateral prostatic carcinoma will have irregularity on both sides and will have obliteration of the sulcus, most likely, at least a very irregular sulcus.
Okay, to the question of what to do with your finger when it's actually inside the rectum. So what do you do? We talked about what to do in terms of the procedure, but what does your actual finger do? And it's interesting because you look at different websites, and some of them have this idea of inserting the finger and then just sort of poking the prostate, boop 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 boop, and that's a very bad thing to do. What you're doing with a PR examination is you're using the pulp of your finger once it's inside. So you'd first do the squeeze test, and then what you're doing is feeling the inside of the mucosa, the lining of the rectum, to feel what the consistency and the texture feels like. So it should feel smooth, and it should not be tender, and there might be fecal matter in there, fecal masses in there, and so forth. If it's an unprepared bowel, and then you're feeling for any masses, feeling for any tenderness, and feeling for the quality and the texture of the inside, the lining of the rectum. When you're then feeling for the prostate, you'll feel that the rectum will glide over the prostate, and you'll be able to feel the sulcus. As you can see here, this is the 3D printed prostate. The different lobes there, and you'll feel the sulcus with your finger, and then you'll feel the lobes, which will be the right lobe or the left lobe, and you can't get that far round the prostate or too far above it, but you're feeling the consistency and everything else we mentioned there, the consistency, the texture, the smoothness, any abnormalities, any irregularities, and any asymmetries. You're not going in and poking it. You're not scratching the rectum. So don't go in there with your finger and start poking around and start scratching or trying to see what the integrity is like. That is not the point of it. The point of it is to get an appreciation of what the inside of the rectum is like. Are there any masses? Is there any irregularity? Of course, any tenderness, and then to feel the prostate. Now, the other thing is to mention is that, of course, if we pretend that this is a uterus now, the uterus is in front of the rectum, as is the vagina, and so sometimes you will be able to feel masses which are related to the uterus, and possibly the vagina, and also if you can feel masses to the side. Then in a female patient, then that could be a sign of any ovarian pathology, especially if there's any tenderness in the sides. Sometimes that can be a sign of an ectopic pregnancy. So that's what you do when your finger's in there, and it's gentle as well. It is not firm palpation. No, don't boop it and don't push it too hard and scratching or anything like that. And also make sure your fingernails are prepared as well. They need to be short, and not cause any trauma. Okay, thank you.
Now, just a quick run through of the information in the handbook. The usual aspects of introducing yourself, getting the name and date of the patient, explaining the procedure and gaining consent, washing your hands, adequate exposure and positioning of the patient, commenting on the end of the bed for the usual stuff. I mean, in the handbook, it says stuff which are really the things that are mentioned in the handbook really aren't appropriate to a patient where you're going to be examining the prostate more than likely. It's catheters, catheter bags, potentially a suprapubic catheter, whether they, and then moving on to general inspection. With regards to their body habitus, you might be looking at patients who've got loose clothing, who've lost an idea that they might have lost weight. Could they be cachectic? And do they look unwell? Another thing that might be on the surrounding area, just mentioning it, is the potential for urine bottles as well. Now, in the inspection, again, preparation, it's gloves, because you're going to come in contact for definite with bodily fluids, and you need to uncover the patient. The patient should be on the left lateral position with the knees drawn up. The examination of the perianal area is very important, really, and it involves parting the buttocks and having a look at the skin and looking for any signs of erythema, any breaks in the skin, any excoriation, fistulas, skin tags, hemorrhoids, fissures, blood, and any pus, of course. Um, and also signs of fecal matter if there's any incontinence as well, which is it's worth mentioning. You'd certainly want to mention a few of these elements. It's also very important before that you insert the digit and ask them to bear down that you test the perianal skin sensation. Um, it's especially important when it comes to concerns about spinal cord injuries, where you know another DRE. But in general, it is always a good idea to understand whether or not the perianal skin sensation is compromised or not. Then preparation, you want to make sure that you have your water-based lubrication jelly available to you prior to getting to this position, and then you want to put it on the index finger. I think this point about running the finger on the natal cleft to the anus. I mean, you've just done this to the perianal skin sensation, so you shouldn't really need to do this maneuver. And I think it's then it's gently explaining that you're going to put it in, and some people also say take a deep breath and warn the patient when you're going to insert the finger into the anus. Initially, it's just the fingertip really, because you're going to ask them to squeeze your finger to assess the anal sphincter tone. And again, this fits with the element of checking anal perianal skin sensation. And saying something like, it's if you could try to bear down or stop urination, something like that. Just pretend you want to stop going when you're going for a wee, that kind of thing. Is it's all perfectly reasonable as long as you can get them to squeeze your finger. In all fairness, most patients will just be able to squeeze your finger. So let's just move on. So then you're really telling the patient again that you're going to move the finger further in to examine the rectum. And then you're going to examine essentially sequentially, most likely the posterior wall first, and then the right side, because then you've got to kind of sweep down to the left before you can get your finger to feel anteriorly and forward. And if you see in the video, you kind of really, to do this effectively, you really do have to to get your forearm to pronate quite almost fully, and often that means lowering your body down to get a good appreciation of the prostate. You feel the left lobe first, then the sulcus, and then the right lobe, or the sulcus, then the left lobe, the right lobe. And you really are feeling, when you're feeling the tissue there, you are assessing both the quality and any abnormalities, any firmness, any masses, anything unusual on the surface of the rectum. And then again, for examining the prostate, you're going to be looking at the consistency of it, the shape of it, the symmetry of it, any tenderness, and any sort of enlargement. And then after that, you're going to withdraw your finger. You warn the patient before you're going to withdraw the finger, and then you're going to examine the finger for the fecal stain or fecal smear, which is going to be essentially checking for blood, mucus, fecal matter. If there was something like pus there, you might also see that. You might also note fresh blood. It might be obvious fresh blood, but also looking for melena and commenting on melena. And then when you finish doing that, then offer to wipe the patient. Often you'll wipe to something to a certain extent, and then offer and then hand the patient some paper to do so, and then ensure their dignity as much as possible by covering them up as much as possible. Now, then you're going to move on to talking about what you would do after this, and taking a full history, examining the abdomen and the lymph nodes and the genitals are additions to the DRE. But in a real situation, you wouldn't have got to be doing a DRE if you hadn't done all of this other stuff first. And if it's in cancer, you'd consider the potential metastatic spread and making sure you do a full systematic examination. Now, moving on to the appropriate investigations. There's blood markers, of course. Now, PSA is one of the important markers for a prostate examination, and you've got to make sure you mention that this is something you would have done prior to the the DRE examination. Also, you have other hormonal markers which can be done afterwards. Now, it's also important to understand that biopsying is one thing, an ultrasound guided biopsy, and carrying out an ultrasound, but quite commonly carried out now these days prior to other investigations is a CT scan. So CT and ultrasound are your main forms of imaging now. And lastly, just remember to squirt the alcohol gel on your way out, and have a think about differential diagnoses and management plans, and that could come up theoretically as extra questions. Right, well, that brings us to the end of the DRE session. I would implore you to go and have a look at these models as well, and just so you can assess yourself and practice with the models, just in case these came up in an examination. But in general, it is a skill that you do need to know how to do. It's very important. Please leave comments below.